Adelante, ya están en vivo.
César.
Empiezas tú, Leonardo.
Ok. Muy bien, muy buenas noches. Tengan todos ustedes un gusto saludarlos. Hoy en esta sesión académica del Colegio Médico de Ortopedia de Jalisco, a quien les enviamos un fuerte abrazo y felicitamos por abordar este tipo de temas. Curso virtual, un curso hablando de nuevas técnicas en el manejo de las pérdidas cutáneas. Muchas gracias a todos, recordándoles que la plataforma de femecotvirtual.com está a la orden de todos ustedes para que sigan todas las sesiones académicas de la Federación, también el webinar FEMECOT, y que puedan también obtener puntos para la vigencia de certificación. Saludo con mucho gusto al doctor Darío Esaugarín Certuche y a todo el grupo de profesores, y también al doctor César Augusto Álvarez Rengifo, presidente del mismo colegio, a nuestro coordinador, el doctor Luis Gerardo Padilla Rojas. Buenas noches a todos, grupo de profesores. Gracias por su ayuda. Adelante, Darío, por favor.
Gracias, doctor López Almejo. Muchas gracias y bienvenidos todos. Gracias, César Álvarez Rengifo, por la invitación. Y todo un honor estar aquí con el Colegio de Ortopedia de Jalisco, con un excelente tema, con excelentes ponentes. Y bueno, creo que con una institución bastante importante en California y en Estados Unidos. We thank you very much, all of you professors from UCSF, for being here. Thank you very much. On behalf of the Scientific Committee, we welcome you and thank you very much. César, por favor, muchas gracias y adelante, por favor.
Gracias, doctor Darío. Gracias, doctor Leonardo. Primeramente, quiero, en nombre del Colegio de Ortopedia de Jalisco y de la mesa directiva, y pues agradecer a todos los participantes. Creo que va a ser un tema muy interesante. Agradecer de antemano a FEMECOT, por su dirigente, excelente presidente, el doctor Leonardo López, y el vicepresidente, el doctor Darío, que acaba de verlo, siempre ellos en la mira, ayudándonos y haciéndonos el favor de acompañarnos a pesar de sus múltiples ocupaciones. Muchas gracias, muchas gracias. Igualmente quiero agradecer al doctor Luis Padilla por contactarnos con los profesores que hoy tenemos, un panel excelente, provenientes de San Francisco, California, la universidad, y muchísimas gracias a todos los profesores. Seguramente vamos a tener una plática realmente, ¿cómo se llama?, que nos va a ayudar mucho para nuestros pacientes. In special, I want to say thank you to Dr. Nicholas Lee, who helped us all many times, Dr. Michael Terry, Raymond Ragozar, and Anthony Dean. Thank you very much, because you take the time to be with us and to make this webinar possible. I'm sure you have a lot of things to do, but thank you for taking this time to give us all this acknowledgement that's going to help us a lot. Thank you to the university too, that have this convenience with us. And now voy a continuar con el doctor Luis, dándole la palabra para que él nos introduzca con el tema de la plática y nos ayude con la coordinación. The next is going to be Dr. Luis Padilla, and he's going to make the coordination. And after the professors, we're going to have a surprise with the cases, with going to be a little bit of discussion about it, and then the questions. Thank you very much again, Dr. Luis Padilla. Luisito, muchas gracias.
Gracias, buenas noches a todos. Antes que nada, el tema es de relevancia muy grande, porque aquí en Latinoamérica no tenemos un protocolo estandarizado en relación al manejo de las fracturas expuestas. Cada quien tenemos un método en los diversos hospitales, algunos sistemas, pero hay mucha variación. Sabemos que las fracturas abiertas es una causa de discapacidad muy importante en nuestro medio, las complicaciones que esto puede traer. Así que el cierre primario ya sabemos que disminuye la posibilidad de infección y de no unión en las fracturas expuestas. Pero me voy a tomar la libertad de presentar al doctor Nicholas Lee, que es cirujano ortopédico y traumatólogo, cirujano de mano en la Universidad de San Francisco, en la Universidad de California en San Francisco, y que nos ha preparado este curso en la importancia de las nuevas técnicas de cobertura cutánea. Él va a presentar al resto del equipo. Gracias, Nicolás. Your audience.
Yep. Great. One. Ok. Luis, muchas gracias por esta invitación. Como siempre, es un placer estar aquí esta noche con ustedes. Me encanta hacer estos webinars o estas interacciones con sus grupos, con Femicot, porque es un grupo muy, muy agradable. Quiero reconocer al doctor Luis Padilla y doctor César Rengijo, que nos han dado esta invitación para hablar con ustedes sobre este tema. De las panelistas, como me llamo Nicolás Lee, soy un ortopédico y soy cirujano de la mano. Tenemos Michael Terry, que es cirujano plástico y cirujano de la mano. Dr. Payman Ragazar, que es cirujano plástico y de la mano. Y Dr. Anthony Ding, que es cirujano ortopédico, traumatólogo y de la mano también. El modelo tradicional de la escalera reconstructiva empieza con la cierre de primera o segunda intención, el colgajo de piel, colgajo local o el colgajo distante. Pero este modelo tradicional de cobertura de tejidos blandos ha evolucionado hacia diferentes paradigmas con diferentes tecnologías dependiendo de la habilidad y disponibilidad del cirujano. En este ejemplo aquí tenemos el escalera de Gottlieb, que a veces en vez de ir se puede ir a la herida directamente al elevador microvascular, si tenemos cirujanos plásticos o cirujanos que puedan hacer estos tipos de cirugías. Pero la escalera que quiero charlar con ustedes hoy es esta escalera. Y voy a hablar por un poco sobre matrices térmicas. Dr. Michael Terry va a hablar sobre colgajos fascicutáneos locales. Dr. Payman Ragazar de colgajos regionales rotacionales. Y Dr. Anthony Ding sobre colgajos libres. Voy a empezar con uno de mis casos. De este paciente que tuvo una trauma en la mano, tuvo una necrosis del piel. Y cuando hice el desprendimiento, tuve esta herida que pude cerrar aquí, pero tuve tendón libre sin cubierta. El tamaño de esta herida era 4 por 4 centímetros. Y de las opciones que tuve en nuestro hospital, tenemos cordón umbilical criopreservado con células madres mesenquimalales. Esta tecnología empezó en 2015. Se puede poner estas células vivas a negative 80 degrees y le pones un poco de saline y se puede ponerlo así. ¿Okay? Y esto en una semana, se ve así, se ve un poco podrido, como pus. Al segundo semana también se ve necrotizado. Pero esto es lo que se debe ver, así se ve, esto es normal. Y es posible hacer un injerto de piel a la primera semana o segunda semana, pero este paciente que tenía 80 años eligió esperar. Y esperamos por 3 semanas y se ve así. 4 semanas. Y ahora era mitad del tamaño, 2 por 2 centímetros. Esto es la herida a semana 6 semanas. Y esto es el puño. Lo importante es que este paciente, cuando tenía matriz, yo le dejé usar la mano para mover la mano. Y también a las 6 semanas el señor empezó a jugar golf. Y esto es a 7 semanas. La herida se está volviendo más chico. Y a 9 semanas. Y esto es el resultado a 4 meses. ¿Okay? Entonces, la pregunta es, ¿podemos utilizar estas matrices dérmicas para heridas abiertas con hueso o placas expuestas? En 2021 todavía la respuesta es no. Las matrices dérmicas todavía son bastante limitadas, por lo que dedicaremos la mayor parte de este seminario web a discutir colgajos vasculáres locales, colgajos regionales rotacionales y colgajos libres. Muchas gracias. Mike. Y ahora me gustaría presentarle a Dr. Michael Terry, que va a hablar sobre colgajos fascicutáneos locales.
All right. If you could unshare your screen.
Luis, can you unshare my screen, please?
There we go. All right. Well, good evening, everybody. And thanks to FEMICOT and thanks to everybody for allowing me to speak. It's a great honor. I'm going to speak to you now about local fasciocutaneous flaps and perforator flaps and coverage of the, specifically for coverage of wounds of the distal third of the lower extremity. So what I'm going to try to cover in this talk is a brief overview of how we classify flaps. And then I'm going to go over the design and technique for various local flap options. And keep in mind that, we're going to be focusing on extremity wounds and extremity surgery here, but these are techniques that you can carry with you to wounds all over the body in other locations as well. And then finally, I'm going to touch on the delay phenomenon, which is a method for increasing the vascularity of your flaps. So starting off with a case, we have a 50-year-old woman who was in a motor vehicle accident. She had an open tib-fib fracture that was treated with an IM nail. 9 months later, unfortunately, she presented with an infected tibia and a draining sinus. She underwent multiple INDs and then placement of removal of the rod and then placement of an antibiotic spacer, which because of the bulk of the spacer and because of the size of the wound, she was left with an area that could not be closed primarily. So we were faced with this wound. And, normally in this day and age as plastic surgeons, when we are faced with wounds of this nature, wounds of the distal third, significant wounds, we tend to jump to microvascular free tissue transfer. But there are several situations in which there are local options or regional options which can also be used to cover these wounds. Now, distal third options are limited, and local vascularized tissue movement requires anatomical precision. So we're going to try to go over some of the techniques of local flaps here so that everyone can have these tools in their toolbox when they're faced with these types of wounds, and they may not have access to microvascular surgery. So we're going to cover fasciocutaneous flaps. I'm also going to touch on perforator flaps as well. So the basics of local flaps, well, just like the name implies, local flaps utilize tissue adjacent to the wound to transfer over and cover the wound. And as I mentioned before, they can be used for wounds all over the body, not just specifically for extremities. One good example are pressure wounds. So sacral pressure wounds are very good options for different kinds of local flaps. The good points about using local tissue transfer and local flaps is that it does not require special instruments or microvascular skill. And we're going to talk about the basic principles of the design. So briefly, to talk about classification of flaps, the most basic and easy way to classify flaps is according to tissue type. So we have, obviously the tissue type is skin, fascia and skin, muscle, muscle and skin, etc. But arguably more important is the vascular classification of flaps. The whole key to ensuring that your flap will survive and that you will not undergo partial or total flap necrosis is to have a complete grasp of the blood supply of the flap. So that is absolutely essential in order to do these type of flap surgeries. You must understand the blood supply to the flap and how to design the flap so that there will be adequate blood supply. And again, we're going to, all the flaps, most of the flaps we're going to talk about are random pattern flaps in terms of their blood supply, as opposed to axial or arterial based flaps. And we all understand the circulation of the skin, but just to review, it's good to have a solid understanding of the different vascular plexuses at different layers of the skin. So we have our regional artery, which is usually a named artery like the radial artery, which sends off perforators, and those perforators are classified according to the tissue they travel through. So perforators that go through muscle and up to skin would be musculocutaneous perforators. Perforators that travel in the septum between the muscle and up to the skin would be septocutaneous perforators. Also to keep in mind the subfascial and prefascial plexuses, as well as the subdermal plexuses. Okay, so what is a random flap? Well, a random flap, as the name implies, is based on the random circulatory pattern in the subdermal and fascial plexuses. So your flap is completely supplied by these random small vessels as opposed to a larger named vessel. Here's another slide illustrating that principle. You see, looking down at an area of skin on the left, you have random blood supply coming in from all directions. If we were to create a rectangular transposition flap and incise along the 3 borders of this flap, then we have cut off the blood supply along those 3 borders, and the sole blood supply is now coming in from the base of the flap. And as you might guess, the further the blood supply has to travel, the weaker it gets. So there is a limit to how long we can make these flaps relative to their width. And the standard limit to that is a 2-to-1 length to width ratio. So that is a key number to keep in mind when designing local flaps. They must be within that 2-to-1 length to width ratio, with certain exceptions, which we'll get to towards the end. Okay, here's the first type of flap we'll talk about. This is a basic transposition flap, similar to the previous slide. It is a rectangular flap. For any basic wound, you can design this rectangular transposition flap adjacent to the wound. A couple important design points is that the apex, the corner of the flap, from the base of the flap, the far corner at the base, that from that point to the furthest point of the wound, that distance must be equal to or less than the distance from the corner point of the flap to the distalmost tip of the flap in order to allow a geometric rotation into that defect. Now, one principle that you can carry with you for all flap design is that when you rotate tissue, you always lose a little bit of length when that tissue rotates, just due to the inherent inelasticity of that tissue. So we design flaps based on geometric principles, but keep in mind that you should design your flaps with a little bit of extra length built in to account for that. Okay, so here's one example. We have unstable scar, we have an open wound, and we want to cover that. So the unstable tissue is excised, and the transposition flap has been designed. And you can see the transposition flap now rotated into position. Now, when we rotate transposition flaps, of course, we are leaving a defect in the donor area where the flap arose from. You might ask, why would we trade one wound for another wound? Well, what we are doing is we are trading a critical defect, exposed bone, exposed hardware, exposed tendon, which must be covered with vascularized soft tissue, for a less critical defect, which is a vascularized wound bed, which can be covered with a skin graft. One more example here, and we see that there is incision, which limits the distal extent of the flap. So we have to make a fairly large flap in order to cover this wound, but we are able to get it well approximated. And then the donor site is skin grafted, which you can see posteriorly. And those go on generally to heal very well. Okay, the second type of flap we will cover is a rotation flap. And as the name implies, a rotation flap is simply a circular arc extended from the wound, which the wound can be circular or it can be triangulated, as demonstrated in this diagram. one key design point for these rotation flaps is that the length of the arc should be at least roughly 4 times the width of the defect. And the reason for that is because the tension that you would normally accumulate by trying to close this wound primarily is distributed along the entire length of the arc. So the bigger the arc, the less tension is on each point along the arc. So as a general principle, try to make your rotation flaps very big relative to the wound. Another illustration here demonstrating the principle, and then some clinical examples here. So after debridement, we have a wound with exposed bone, and we've designed, as you see, a very large rotation flap relative to the wound. Especially in the lower extremities, the tissue does not rotate as well as, say, on the buttocks or on the abdomen. So you do have to take that into account and design relatively large flaps. And we have skin grafted the donor area in this situation. In many situations, you are able to close the entire length of the arc primarily. Now, here's an example, as I mentioned, on a different part of the body. Here's a large sacral pressure wound, and you can see that we make the rotation flap extend as far possible along the buttock in order to raise a big flap which can rotate in and cover the entirety of that wound. The third type of flap we're going to cover are for small elliptical wounds such as this. We are in the dorsum of the foot where there is minimal tissue laxity, but it is a relatively small wound. So how would we close this? The next set of flaps is called a bipedical advancement flap. And the theory of that is that we have a elliptical wound. Here's a diagram. And then we create 2 incisions along either side, which are at least the diameter of the wound. And now we have set up a set of random flaps. You can think about this as a set of 4 transposition flaps. We have 2 on each side with blood supply coming in from proximally, blood supply coming in from distally. So those 2 lateral incisions are created, incise the fascia, and then the tissue is undermined and then advanced towards the center in order to close the wound. And then you have 2 donor site areas which should be able to be skin grafted. And here's the clinical example. So we've made the 2 lateral incisions and advanced that tissue medially, centrally, and closed with sutures. We've gotten our critical defect, the exposed tendons covered, and we've left behind a vascularized wound bed, which can be closed with a skin graft. The next flap is a simple advancement flap. And again, as the name implies, this just implies advancing the tissue into the wound instead of transposing it from adjacent to the wound. The most common variation of this flap is the V to Y advancement flap. And as you can see from this diagram, it gets its name from the geometry of the flap. It starts out as a V shape. The V is incised, and that tissue is mobilized forward into the wound, and then it is closed in the illustration below. You can see in a Y pattern. And you might ask yourself, well, if there's a wound on the base of the triangle and then the 2 sides are incised, where is the flap getting its blood supply from? So the key to that is that the flap remains attached at the deep surface of the flap. So there are perforators that come from that tissue and supply the flap. Very important principle with this type of flap is that you must incise the fascia along those borders of the flap in order to get enough release to advance your flap into the defect. Here's a case example illustrating this principle. We've designed our V portion of the flap here. This is a skin cancer defect on the face. We've incised our flap down through the fascia, now mobilizing it into the wound, securing it, and then closing the tissue in the Y pattern. Okay. And the final concept I'd like to talk about is the delay principle. Sometimes you may need a flap that exceeds a 2-to-1 length to width ratio because there's not really much alternative. So this is a technique whereby we can attempt to increase the blood supply of these flaps. So the delay principle involves improving flap survival by incising a part, but not all of the flap borders. What that will do is it will decrease the blood supply to the flap, but still leave enough blood supply to keep the flap viable. Then you would wait anywhere from 4 days to a week to allow the remaining blood supply. Those blood vessels will dilate up, they will accommodate, and they will increase in caliber, and then be able to supply a longer portion of flap that would otherwise have undergone tip or distal tip necrosis. So here's a diagram illustrating this principle. We've got our random area of skin with random blood supply coming from all directions. And we have a long, in this case, 3-to-1 length to width ratio for a transposition flap. Instead of incising all of the borders, we incise 2 lateral borders. We wait a period of time, and then the proximal and distal blood flow increases in caliber. And then when we come back later for a second operation, we were able to complete the transposition flap by incising that last distal border, elevate the flap, and transpose it into the wound. And because that proximal blood supply has increased in caliber, then that flap hopefully should be able to survive. Okay, so here was our original case, and what did we end up doing in this situation? Well, we did a simple transposition flap. So here's our rectangular flap, elevated and swung over, and with a skin graft at the donor site. And if I believe we have enough time, I'm going to touch briefly on perforator flaps. So now this is a more complex type of flap. This is a flap that is not based on random blood supply as all the previous flaps were, but on, as I mentioned, perforators that come from the deep surface. Those can be musculocutaneous perforators or septocutaneous perforators. So understanding the perforator anatomy is critical in order to design these flaps. So one essential piece of equipment that you must have is a handheld Doppler. And then you can design out, here on this diagram, you see the X marks illustrate where the Doppler has identified perforating vessels to the skin. And then you can design your flap around those perforating vessels, which is done here. Just in this case, only the anterior border of the flap has been drawn. The posterior border has not been drawn at this point. There is the flap elevated based on those 2 or 3 perforators. And if you extend the proximal portion of the flap, you can rotate that flap around, keeping those perforators intact in order to cover this distal wound. There are the perforators illustrated, you can see. And again, another illustration. And now this is the flap rotated into position. It's been completely mobilized only on those perforators. And then the donor site from the flap is skin grafted. Okay, so just to review, distal third of the lower extremity, very difficult locations, but you don't always need a microvascular or a free tissue transfer solution. There are opportunities to use local tissue transfer, as we've talked about here today. Very important and very key to understand the arterial and venous anatomy of whatever flap you are designing. Moving on to perforator flaps, those can be a good option, but they do require more technical expertise to dissect those perforators out without injuring them. So thank you, everybody, very much, and I appreciated the chance to talk.
Muchas gracias, Dr. Terry. Ahora le presentamos a Dr. Payman Ragazar, que nos va a hablar sobre colgajos regionales rotacionales.
Buenas noches, gracias por invitarme a hablar sobre el tratamiento de heridas en la extremidad inferior con colgajos rotacionales. Los principios primarios de los colgajos rotacionales incluyen el uso de tejido adyacente al defecto, la rotación alrededor del aporte vascular, el pedículo, y por lo tanto no es necesario la microcirugía. Es importante comprender que los colgajos rotacionales no son la mejor opción para todas las heridas. Tienen un alcance limitado por su pedículo vascular y por lo tanto no pueden cubrir heridas distantes. Además, en casos de trauma, el colgajo puede estar dentro de la zona de lesión o inflamación. Finalmente, es posible que deba realizar un injerto de piel para el sitio donante. Los dos tipos de colgajos rotacionales para extremidad inferior que discutiremos hoy son el colgajo de gastrocnemio y el colgajo de Soleo. Empezaremos por el colgajo de gastrocnemio. En general, las indicaciones de un colgajo de gastrocnemio son heridas en el tercio superior de la pierna. El colgajo de Soleo, del que hablaremos después, está indicado por heridas del tercio medio. Este es un ejemplo de una herida donde el colgajo de gastrocnemio está indicado. La anatomía del músculo gastrocnemio incluye el origen del músculo de los condilos femorales y la unión al tendón de Aquiles. La función muscular es la flexión plantar de la piel. El suministro vascular o el pedículo son las arterias surales lateral y medial que surgen de la arteria poplitea. La arteria poplitea es una continuación de la arteria femoral. La arteria sural lateral suministra el gastrocnemio lateral y la arteria sural medial suministra el gastrocnemio medial. El nervio tibial emite nervios surales medial y lateral que acompañan a los vasos. El gastrocnemio es un colgajo tipo 1 de Mathesina High con pedículo simple dominante. Se puede utilizar un gastrocnemio medial que está suministrado por la arteria sural medial o un gastrocnemio lateral que está suministrado por la arteria sural lateral. Las cabezas medial y lateral están separados por un tabique fibroso que incluye el nervio sural y la vena safena menor. Esto puede servir como un buen punto de referencia. Otro buen punto de referencia es el tendón plantaris. El tendón plantaris se encuentra entre el gastrocnemio medial y el músculo sóleo y es una buena forma de identificar el plano de separación. Este es un esquema de los detalles del flap de gastrocnemio que ahora discutiremos. Comenzaremos con el diseño de la incisión. Los puntos de referencia para el colgajo incluyen la línea transversa en surco posterior de la rodilla, que también corresponde al punto de partida aproximado de los vasos surales medial y lateral. El rafe de la línea media también es palpable y sirve como marcador que separa las cabezas de los músculos medial y lateral. La posición más fácil para realizar la cirugía del colgajo de gastrocnemio medial es con la rodilla flexionada y la cadera en abducida, flexionada y rotación externa. Encuentro que es más fácil hacer incisiones que se extiendan desde la herida en sentido posterior y distal y a veces incluso un sentido proximal, si es necesario. Esto creará un colgajo de piel grande y una buena exposición para la disección. Alternativamente, se puede hacer una incisión posterior y medial separada como se muestra aquí. Aquí se muestran más ejemplos de las diferentes formas en que se pueden diseñar las incisiones. A menudo puede diseñar la incisión para conectar otras heridas cercanas como un defecto en la piel de un dispositivo de fijación externo. Ahora discutiremos la elevación del colgajo. Eleve los colgajos de piel lateralmente hasta que se identifica la división entre las dos cabezas del gastrocnemio. El punto de referencia entre las dos cabezas será el nervio sural y la vena safenada menor. Se puede desarrollar un bonito plano entre el gastrocnemio y el soleo. Un buen punto de referencia que separa los dos músculos es el tendón plantar. Una vez que haya elevado el colgajo, puede soltarlo distalmente del tendón de Aquiles. El pedículo vascular emerge proximalmente y por lo general no es necesario visualizar el pedículo en la disección. Esta foto muestra esta etapa de la disección con el músculo gastrocnemio liberado del Aquiles y disecado. Esto demuestra el gastrocnemio completamente disecado. Aquí puedes ver el tendón plantaris, el músculo soleo y el nervio sural, que separa las dos cabezas del gastrocnemio. El pedículo vascular del colgajo está así arriba, en la parte más proximal, y no es necesario visualizarlo durante la disección. Continuaremos discutiendo la rotación del colgajo en su posición. Hay un gran arco de rotación y este permite cubrir el tercio proximal de la pierna, así como la rodilla anterior y medial. Además, una técnica que se puede utilizar para ganar longitud adicional al colgajo es realizar una serie de fasciotomías, como se muestra aquí. La longitud aumenta de forma perpendicular a la dirección de la fasciotomía. El colgajo se puede tonelizar debajo de un puente de piel, como se muestra aquí. Tenga cuidado si tuneliza el colgajo, asegurándose de que haya espacio suficiente para permitir cierta hinchazón postoperatoria del colgajo y que no haya compresión en el colgajo que puede afectar su viabilidad. Esto demuestra un recuadro sin un túnel subcutáneo. Esto asegura que no se comprimirá el colgajo muscular. Puedo ver el punto de pivote proximalmente. Aún debe asegurarse de que esta área no está apretado porque el pedículo se origina desde aquí. Esta imagen muestra el cierre de la piel distal y la inserción del colgajo. Puedo ver que se realizaron fasciotomías para aumentar el ancho y el largo del colgajo. Si necesita un alcance adicional, puede seccionar el origen del gastrocnemio medial. Eso aumenta el riesgo de tracción en el pedículo. En ese escenario es importante identificar el pedículo y confirmar que no está en ningún estiramiento cuando inserta el músculo. Por lo general, el sitio donante se puede cerrar principalmente y se coloca un injerto de piel sobre el colgajo del músculo gastrocnemio. Esto demuestra la extremidad después del cierre y el injerto de piel. Otro ejemplo de cierre y injerto de piel. La donador del colgajo gastrocnemio lateral tiene un concepto similar. El nervio sural puede servir como un punto de referencia que separa las cabezas medial y lateral. Sin embargo, el punto más importante es la posición del nervio peroneo común. Hay que tener cuidado de no lesionar el nervio y de presionarlo con el colgajo insertado. Es menos común usar el gastrocnemio lateral, ya que el gastrocnemio medial es más grande y puede cubrir un área tan grande. Sin embargo, esta foto es una buena demostración de un caso en el que estaría indicado un gastrocnemio lateral con plata expuesto. Si se ha colocado una marca sobre el área prevista del nervio peroneo común. Esto demuestra la elevación del colgajo gastrocnemio lateral. Se pueden realizar fasciotomías para aumentar el alcance del colgajo antes de la inserción del colgajo. Se puede colocar un injerto de piel sobre el colgajo también. El cuidado postoperatorio incluye un vendaje de injerto de piel con gasa de vaselina durante aproximadamente 5 días, una férula posterior durante 2 semanas, carga de peso según la fijación ortopédica y bajar la pierna progresivo a partir de 1 semana. Los resultados después de un colgajo de gastrocnemio son en general muy buenos. Este estudio encontró solo una pérdida del colgajo, una pequeña cantidad de problemas de sanar las heridas y un gran porcentaje de pacientes pudieron volver a caminar y casi la mitad pudo volver a correr. Okay. A continuación discutiremos el colgajo del músculo sóleo. En general, el colgajo de Soleo está indicado para cubrir un defecto de medio un tercio de la parte inferior de la pierna. Esos son algunos ejemplos de casos en los que estaría indicado un colgajo de Soleo. Estas son heridas del tercio medio de la pierna con placas o huesos expuestos. Más ejemplos de heridas con hueso expuesto donde un soleo sería un buen colgajo para cubrir. Similar al gastrocnemio, el tendón plantaris puede servir como un buen punto de referencia para identificar el soleo. El soleo estará profundo hasta el plantaris. El plantaris separa los músculos gastrocnemio y soleo. Aunque mi preferencia es usar todo el colgajo del músculo soleo para cubrir, tiene 2 componentes, una mitad medial o una mitad lateral. Se puede hacer un colgajo hemisoleo para cubrir. La irrigación vascular del hemisoleo medial es irrigado por las perforantes tibiales posteriores. El suministro al hemisoleo lateral lo proporcionan las perforantes peroneas en la mitad superior. El soleo es un músculo multipinado. Hay un rafe que divide el soleo medial y lateral. Si se toma todo el músculo, es muy importante identificar y disecar sobre el rafe para asegurar la elevación de todo el colgajo. Esta es la parte más desafiante de la elevación del colgajo. Analicemos el diseño de la incisión para el colgajo. Aquí muestra el rafe que divide las 2 partes del soleo. Las incisiones, en general, colocamos la incisión aproximadamente 2 centímetros por detrás de la tibial medial. Puede usar las incisiones para conectarse a su herida existente. Cuidado con la vena sáfena y el nervio durante la disección. Okay. Cuando haya retirado el gastrocnemio y haya identificado el soleo, proceda a elevar el soleo de la aponeurosis del tendón de Aquiles. Durante la elevación del colgajo, conservar tantas perforantes vasculares como sea posible. Recuerda, hay un rafe y debe elevar la solapa sobre el rafe. Si no tiene cuidado, puede perder el rafe y accidentalmente solo elevar un hemisoleo. Otra vez, demuestra el rafe entre los dos hemisodios. Rotar el colgajo a su posición. Solo suelte los accesorios necesarios para que el colgajo pueda llegar a la herida. Demasiada disección pone la perfección en riesgo. Insertar el colgajo y colgajo injerto del piel y cierre el sitio donador. Los principios clave de inserción y cierre incluyen la colocación de un drene profundo en el colgajo, la sutura del músculo a los bordes de la herida y evitar la tensión en el colgajo. Similar al gastrocnemio, el músculo puede cubrirse con un injerto de piel sobre el colgajo muscular. Manejo postoperatorio. Coloque al paciente en un vendaje reforzado, una férula posterior durante 2 semanas, elevación estricta inmediatamente después de la operación y bajar la pierna inicia a la semana 1. Algunos principios clave para los colgajos de rotación incluyen estabilizar la fractura, controlar la herida y planear la fijación antes del colgajo. Conozca sus planos de disección y la anatomía del pedículo. Si necesita más extensión, puede cortar la fascia profunda y es posible liberar inserciones proximal para el gastrocnemio. Pero tenga cuidado con el pedículo. Asegure la hemostasia adecuada y coloque drenajes profundos en el colgajo. En resumen, los colgajos rotacionales son una herramienta valiosa y esencial en el salvataje de las extremidades. El colgajo de gastrocnemio se utiliza para las heridas del tercio proximal de la pierna. Y el colgajo de Soleo se utiliza para las heridas del tercio medio. Los pedículos se basan en perforantes de arterias peroneas, tibial posterior y popleteas. El rafe medio divide los lados medial y lateral de Soleo. Hay que prestar atención a todos los detalles cuando realizar estas cirugías. Gracias.
Muchas gracias, Dr. Ragozar. Ahora me gustaría introducir al Dr. Anthony Ding, que nos va a hablar sobre colgajos libres. Y al final de su charla tenemos un caso que Dr. Terry quiere compartir sobre una tecnología que estamos usando aquí en los Estados Unidos para estos colgajos libres.
Great. Thank you, everyone. Thank you for inviting me here, FEMCOD. And I'm going to be talking to you today about free flaps for the lower extremity. A lot of the earlier content has already been discussed by my colleagues, so I'll just gloss over that quickly. Okay, just going over some things that we'll cover. We'll go over some basic principles of flaps. Again, we have gone over a lot of this already in the previous talks. We'll talk about some of the surgical techniques and the postoperative care, which is just important, especially when we talk about free flaps. I will not go over very specific free flaps in detail because of the time constraints of this. There are many, many types of free flaps that you can do, and it's beyond the scope of this talk. Okay. Let's start with some principles and review some of the things we talked about already. We talked about the reconstructive ladder, or some people also call it the reconstructive elevator. It's a way to frame how complex a wound is and what to do with it. So we can start with most simple, or we can go to the most complex. Okay, and with that we have various. The ladder demonstrates how complex our approach needs to be to deal with skin loss, starting with primary closure being the most simplest and going all the way to free flaps as the most complex technique. Okay, Dr. Terry Ray talked about the different types of Classification systems for flaps, we can talk about it by tissue type, whether it's a fascicutaneous flap or a muscular flap, like an ALT flap on the left and this lat flap on the right. Okay, we can also do bone flaps. So these are the osseous flaps. This is a free fibula, or we can even take that with skin. Okay, we can talk about flaps in terms of region. We've already talked about local transposition flaps, regional flaps such as repeller flap or a gastroc or soleus flap, or distant flaps. Okay, and we can also think about it in terms of vascularity, and this is more so for the fascicutaneous flaps, whether it is a random flap, whether it's a perforator flap, or whether it's based on an axial vessel. Okay, this is an example of just the plexices that are seen in the fascicutaneous layers, and Dr. Terry's already covered this when we talked about local transposition flaps. But we can also have fascicutaneous flaps attached to axial vessels. This is an example of a radial forearm flap based off of the radial artery itself. So this is an axial vessel, meaning it's named after meaning that its blood supply is after a named artery. Okay. When we talk about muscular flaps, however, we use the Mathis-Nahai classification. And this tells us that for each muscle, they have different patterns of vascularity. You don't have to memorize all the types. There are 5 types. The main thing to understand from this classification system is what is the dominant pedicle. And by dominant pedicle, we mean that that blood vessel will, in and of itself, supply the muscle, okay, as opposed to segmental or minor pedicles where they will not be able to supply the whole pedicle, right? So for a type 1, for example, you have one dominant flap. This is like a gastroc flap that's off of one artery. So as long as that artery is preserved, the entire muscle will be fed. But you have something like a sartorius flap where you don't actually have a dominant pedicle whatsoever. It's fed by multiple different types of vessels. So these can't work as a free flap because it only supplies a portion. It doesn't supply the whole muscle. So if you were to attach the flap by any one of these segmental vessels, only this one portion would actually survive. Okay. Why do we call it a free flap? We call it free flap because we actually detach it from its native blood supply. We transfer it and then reattach it to a recipient site. So the donor is the free flap. The recipient site is the native tissue bed, wherever that may be. Okay, and so we also call the vessels, like the donor vessels is the vessels from the free flap, and the recipient vessels are within the wound bed itself. This is one example of a distal 1/3 tibia fracture with exposed bone. Okay, so this is the recipient site. Okay, and then the donor site is going to be a free flap. So for this one, we decided to do a radial forearm free flap. Okay, we take it from the wrist and then detach it from its blood supply and reattach it down to the leg to this recipient wound bed and then set it into place. Okay. So what about free flap versus pedicled flaps like the gastrocnemius or local transposition flaps? Oh, I think we have to weigh the pluses and minuses. There are some times when you can get away with it, and that's great because you don't have to monitor it as closely. You don't have to worry about the microsurgical portion of it. Local and pedicle flaps, they are often in the same region as the wound and the same zone of injury. So if you have a very large zone of injury or something like a crush injury to gloving, then that tissue may actually be disrupted. Whereas the free flap has the advantage of being transferred from a different part of the body, right? And ideally an uninjured part, okay? Next, with a local pedicle flap, you're really limited by whatever is around you, right? So you can't increase the size of the gastrocnemius muscle, just whatever is there, or soleus, or you can't change the skin that's in that area. However, with the free flap, because you're taking from distant tissue, you can actually, you have multiple options and you can choose based on what you need in terms of size, tissue type, and geometry. The downside, of course, with the free flap is that you have to do microsurgery for the anastomosis, right? You have to reattach the blood supply, whereas for a local pedicle flap, you're not worrying about that as much. You're maintaining its native blood supply, okay? So the indications for a free flap in a local, in the lower extremity, okay? Generally, we think about these for the 1/3 distal, the distal 1/3 of the lower extremity. Okay, why is it so difficult in the 1/3? Well, first of all, you have limited options, right? You don't have a gastrocnemius muscle belly to cover the wound. You're really limited by the local skin, and after the skin, you just have tendons. Okay, you also need local vascularity. Okay, to implant it in there, and then also depending on where the wound is, for example, a heel pad wound. Okay, you do have to think about whatever you're transferring over being able to withstand weight bearing, right? So you can't just skin graft over a heel pad because it's not gonna be able to withstand that weight bearing portion, okay? So the other thing is that if you need to bring in a different tissue type that's not locally available, okay, you can do that with a free flap as opposed to a local flap. So this is just one case example. This woman had a segmental bone defect, as you see over here, okay? And at the end, we ended up doing a vascularized fibula to make up for the segmental bone defect, right? So we require a free flap to bring in tissue that we need to reconstruct the bone. In a similar way, we can also use a functional gracilis for motor reconstruction, okay? And then the last indication is if we have a large wound that can't be covered by a local or regional flap alone, then we may need a free flap, right? So this is one example. Where you have a large segmental bone defect, but you see it's distal in the middle third. Soleus isn't going to be enough for this. You can see it's a large zone of damage, large zone of injury as well. So local soft tissues and local skin is not going to be sufficient, okay? You have to be especially careful for things like crush injuries, like the gloving injuries, where the zone of injury is pretty large. This is another example where it's actually a proximal midshaft tibia fracture, but you can see just how much the gloving is going on. I mean, the bone can be pulled out of the wound, and you can actually see the tibial nerve as well as the posterior tibial artery, right? So a gastroc soleus, whereas the region is right, there's just too much soft tissue and too much soft tissue damage where that flap will not be, where either a gastroc or soleus will be inappropriate, okay? So the next part is how do you select a flap? Well, I think there are many factors that you have to weigh, and oftentimes there's no right answer whatsoever, okay? So one of the big factors is the defect size, also the tissue type needed for reconstruction. Now, often in lower extremity, you just need some sort of skin or muscle over that. But as I pointed out before, if there's a special need, like there's bone loss, then you may consider like a vascularized fibula, for example. You also want to pay attention to the anatomy of the flap that you're choosing, right? The pedicle length and diameter, especially for the large zone of injuries where you want to actually get outside of your zone of injury to perform your anastomosis. Otherwise, you may run into problems, and I'll talk about that in a bit. And lastly, the surgeon experience, right? A lot of it comes down to preference, how you're trained, what you think works for you. Okay, so this is just one example. These are, again, the left wound you saw before. The right one is a heel wound from an open calcaneus fracture, right? Obviously different sizes, so we're going to choose different flaps for these, right? On the left, an ALT, on the right, a radial form, okay? Again, we talked about the different tissue types, using a bone flap, a free fibula for humeral shaft segmental defect, okay? A pedicle length and diameter, so if we need a very long pedicle, then we may consider something like a radial form flap, okay? Because we take the entire radial artery with it. And lastly, again, surgeon experience, okay? So when we talk about surgical principles, okay, I think it's important to start with the conceptual framework, okay? That even before you think about a flap, you're still talking about the essential steps that you have even before a flap, right? So the first thing is you want to make sure that the wound bed is clean. You want to prepare the wound bed. You want to have stability of the wound, right? And you also want bony stability too, right? You don't want to put a free flap and then have the bone shift all around, okay? And for the wound itself, you want minimal necrosis, and you want to treat the infection, okay, and add to adequate debridement. You don't want to add to infection because that's going to kill your flap. And then you think, once you have those first two parts, then you think about covering, okay? And last part is reconstructing, whether that's ligaments, tendons, bone, okay? For surgical steps, you want to first define and control the wound, and then you can go on to your free flap, right? If you can't define or control your wound, then you're not ready for a free flap, okay? Or any flap whatsoever, right? In terms of my surgical steps, after I define and control the wound, then template the free flap, I dissect out the recipient vessels. Oftentimes I'll have another colleague with me who will dissect and elevate the free flap or vice versa. We harvest the free flap from the donor site. We perform the microvascular anastomosis. We inset the flap, we skin graft the flap or the donor site, okay? And then we do our post-operative management, okay? This is pretty standard steps that we follow in this order, okay? Now for the wound, all right, again, you want a clean and stable wound, okay? When I'm evaluating it, of course, I want to pay attention to the dimensions, not only how big it is in terms of width and length, but also its depth, right? Because that may influence what flap I choose. I care about the location. I care about the integrity of the surrounding tissue, okay? Was there another arterial injury that may affect which arteries I choose to put this flap into? Was there also soft tissue injury? Especially if you're thinking like maybe you can get away with the local or pedicle flaps, is there a large zone of injury? Okay, and does this wound actually need a free flap, or again, if there's minimal soft tissue damage, can get away with something more local? Okay, in terms of evaluating the blood supply, you can get an angiogram to evaluate the recipient vessels, especially if there was some sort of arterial injury and you want to evaluate that a little bit closer. Okay. Now, Dr. Terry already mentioned this already, but you want to measure the critical parts of the wound. So your flap must cover exposed bone, tendons, and hardware, but if there are other areas that can be skin grafted, you don't necessarily need to cover that, okay? But again, when you're templating your flap, you want to pay attention to the critical parts of the wound, okay? And when you're sizing the flap, you want to add on some extra dimensions to it, because especially with fasciocutaneous flaps, there's a natural tendency for it to shrink down, and you don't want to, when you inset the flap, you don't want to really put much tension through it. I will address this again later on, but you want to have some extra room in case you need it, okay? For the pedicle dimensions, you want to choose your flap with long enough pedicle. You want to perform your anastomosis ideally outside the zone of injury if at all possible, because if the recipient artery or the vein is injured due to the trauma, then it may increase your failure risk, right? There may be some intubal damage you're not appreciating. The other thing you want to be careful of that I did not put here is if they have like a DVT, for example, because that may affect your venous outflow. And then something you want to consider is a size match between your donor and recipient vessel diameters. Okay. Something that we can use when we're actually elevating the flap is something that uses a dye. It's called SPY technology. Okay, it's a technique that we can use intraoperatively to evaluate the perfusion inside the flap itself. We use an indiocyanine dye. It's green, and we inject it into the vein. Okay. And then we use a special camera, use infrared light that essentially causes it to fluoresce, okay, to light up. And then we can see what portions of the flap will survive, have enough blood flow to it. This is an example of the machine. I'm going to turn it over briefly to Dr. Terry because he has a great video to actually show how this works.
All right, thanks, Dr. Ding. And if you unshare, then I will, I will share my screen. Okay, so as Dr. Ding mentioned, you know, it's clear from all the talks that blood supply is the most critical factor to any flap, any soft tissue rearrangement. So how can we know that our flap has good blood supply when we're there in the operating room? Well, you can look at it. You can assess capillary refill, bleeding from the flap edges, and those are good methods, but not always perfect. If it's traumatized tissue, it can be difficult to tell what's going to survive, what's not always going to survive. So it's really helpful to have something like this laser angiography with indocyanine green. Here's a case example, open tibia fracture with a lot of degloving. And after several debridements, you see the wound is bigger here, and then it's even bigger. So we've got exposed bone, exposed hardware, exposed tendon, all of which need to be covered. And to cover this large wound, we need a very large free flap. And for this, my preference is a anterolateral thigh flap, and you can design very big anterolateral thigh flaps. Here is an example of the flap after dissection. So this is skin and fat and fascia from the thigh, and you can see here the 3 perforators that are joining together into the main descending branch of the lateral femoral circumflex vessel, which is the main pedicle. So those vessels then get anastomosed. We chose the anterior tibial artery and vein to anastomose those vessels to. And here's the flap inset. And so at this point, we would like to know, since it's such a big flap and those perforators are very small, can we be sure that the entire flap is well perfused? Because this patient had an open ankle joint distally. And so that very distal tip of the flap, the most the part of the flap most at risk is the most critical part of the flap, and that's frequently the case. So we did the indocyanine green injection, and I'm going to start this video, and it takes a few moments, but you will see as the fluorescent dye, it's lighting up the circulation, and it appears very quickly in the well-vascularized tissue. And if you keep an eye on the center, our flap is here, this dark area. And you can almost see the heartbeat of the patient as the dye is pumped through into the flap. And typically with free flaps like this, the small vessels clamp down and are constricted for a period of time after anastomosis. So it does take some time for the perfusion to fully perfuse through the flap. So you got to be patient and give it some time. But after some moments, it looks like this. And then, so here's some pictures. This is the beginning, middle, end, and with a few more minutes, the flap became fully perfused, except for, actually, you do notice it does look a little bit dark at the end here. So the final appearance of the flap with the SPY indocyanine green laser angiography was this. And what you notice here on the right is that this area of darkness that did not become well lit up corresponded exactly to this area of ischemia of the flap. So we took the patient back to the operating room and debrided this area and advanced the flap. By this time, we were able to advance the flap distally and we're able to get skin-to-skin approximation. But we could have looked at this in the operating room and decided to excise this piece of tissue in the operating room as well and avoided the second take back. But this is just a good example that shows the proof of principle that you can really see what's vascularized and what's not vascularized with this technology. Okay, and that's it for that case example. Tony, you're muted.
Sorry. I was saying that the technology is really cool, and it's great that you can get that information in real time to maybe even change intraoperative decision-making. I'm just going to briefly review microsurgical technique. When you're attaching the vessels, I usually clamp the vessel ends, dilate the ends, clean the vessel ends of adventitia. Take your time with this. Irrigate with heparinized saline. For me, I'd perform anastomosis with simple 9/0 sutures. You want to avoid backwalling. What do I mean by that? Meaning that you throw your sutures, but instead of just going through the wall, you actually grab the lumen, the other side of the lumen, and you end up closing down your vessel. So you don't want to do that. After performing anastomosis, the patient gets a bolus of heparin, 5,000 units, and then I remove the clamps and check for pain, seam leaks. Okay, how do I do this? Well, I use a strip test. Okay, and all I'm doing is I'm grabbing distal to the anastomosis. Okay, I'm clearing out the blood with one of my forceps. Okay, and then I'm releasing the second forceps that are close to the edge, and then this should fill up very briskly. Okay, the other way you can do this is a Doppler. Okay, both the arterial and the venous signal. Okay, something else that we have used in the past several years is a coupler device. So same steps as just if you're sewing, but you can skip the sewing part. You have the coupler device has these tines where you just put the edges of the vessels around, and then you are able to close the two ends together. So it takes the place of having to perform all the suturing under the microscope. Okay. Okay. Now, there are several principles that you have to follow through when you're insetting a flap. And trust me, sometimes I have ignored some of these principles or been a little bit lax about them, and I paid for it. So the first thing is that you need to cover the critical part of the wound. Okay, exposed tendon, bones, joints, hardware, but you can skin graft the non-critical parts. Okay, you want to have a loose closure. You don't want to have too much tension on the flap. Okay, so that's why you want to design a flap larger than anything you need. If you over-tension a flap, especially fascicutaneous flaps from the top, okay, and you make it very tight on top, what's going to do is actually going to put pressure down deeper. okay? And if your vessel's right there, it can actually put too much pressure and actually occlude and thrombose the vessels, okay? So you wanna be very careful about this. I don't always put drains around there. I know some of my, the people I trained under always put drains under. I think for me, it depends on the amount of bleeding I have. The purpose of the drains is to prevent hematoma or seroma. And lastly, I check pulses pretty regularly. Okay, I check it after anastomosis. I check it after insetting. I check it after putting on dressings. You want to just make sure that at any step you have not caused any damage to the anastomosis itself. Okay, I also will mark that where I heard the pulse with the suture for postoperative monitoring. It helps the nurses a whole lot. Okay. Now, remember that for postoperative monitoring, it's just as important as actually performing the surgery itself, okay? The goals of postoperative care is to improve flap survival. So we do vascular monitoring pretty closely. We do some strict elevation, followed by a progressive dangling protocol. I put on a warming blanket. If I need to, I put in a drain to prevent hematoma or seroma. The hematoma or seroma can actually cause pressure around the vessels and can actually cause them to thrombose as well, okay? And I avoid pressure on the flap or pedicle. So for example, if you have one that's sitting on the back of the leg, you wanna actually float the leg or elevate the leg to avoid any sort of pressure, okay? The other goal of postoperative care is to improve the skin graft take, whether it be from the donor site or an area of the wound bed that's non-critical. Okay, I also do 2 weeks of mobilization, just like Dr. Vacasar said. Okay, this is sort of my protocol. Everyone has their own different protocol. For me, for the first 24 hours, they're getting Q1 hour checks. The next 24 hours are getting Q2 hour checks. And then the 3 days after are getting Q4 hour checks. And this continues throughout their hospitalization. I give a 5,000 unit bolus of heparin at the time of the anastomosis. Again, there are many protocols that people use. There's not one way to do it. I think a lot of it depends on your understanding of literature, your own personal experience, the way that you're trained. People can use heparin, dextran, aspirin. When I was training, we were sort of drifting away from routine anticoagulation afterwards, aside from just aspirin. But certainly if you have to take back a flap, I put them on anticoagulation. Okay. Something else that we've used more recently as well in newer technology is putting an implanted Doppler. Okay, this is a silicone cuff that you can put downstream on either the artery or the vein. Okay, and just wrap it around the vessel. And this is the probe that attaches to it that goes out through a wire. The wire exits out of the skin. You can suture it to the skin, and it gets hooked up to a device. So instead of having to use a probe from the outside and find a pulse, you just turn on the machine and you should instantly hear either arterial or venous signal. Okay. For dangling protocols, just like with anticoagulation protocols, there are multiple different types of protocols. The main idea is that you're trying to prevent excessive swelling of flaps. So as the vessels are sort of readjusting to its new wound bed and to the recipient vessels, the blood flow may not be as great, right? So you want to condition the flap to actually tolerate any sort of swelling, as well as increase venous pressure from gravity. Okay. Again, multiple protocols. This is sort of my protocol that I use. I hold off on dangling for the first week, and then I progressively dangle them. First, 1 minute, 3 times a day, then 2, 5, 10, 15, 30. But again, they're all different types of protocols that you can use. Okay. In terms of looking out for complications, okay, you want to be aware of venous congestion. This is one of the most common reasons for flap failure. You're going to see purple discoloration of the skin for fasciocutaneous flaps. You'll get swelling in the flap, so it'll look shiny. You'll see pronounced pores, so that you'll see the follicles better. Arterial insufficiency will, for a fasciocutaneous flap, it will look pale. You'll lose your arterial signal. Okay. For a muscle flap, it's a lot harder to detect venous congestion in a muscle flap, just because it's all red and it's hard to tell, is it becoming a little bit redder? Is it going a little purpler? Is it light red? It's unclear. So sometimes for this, we take a skin paddle with a muscle flap to improve monitoring. Okay. In conclusion, free flaps is the last part and most complex in the reconstructive ladder. It's typically used for a distal and third extremity wounds, for different types of tissue reconstruction like bone or functional muscle flap, and for wounds that can't be covered with local regional flaps. Okay. Your selection is based on defect size, tissue type, pedicle length and diameter, as well as surgeon preference. And remember your conceptual framework for treating traumatic soft tissue loss, right? You still have to abide by the basic principles to have a clean wound first, stabilize the bone and the wound bed itself, and then think about covering. Okay. Some technical points for success: select appropriate flap that will cover the critical parts of the wound. Give yourself extra room, add some extra centimeters. to the flap to minimize tension when you inset it. You want to pay attention to good microsurgical technique to decrease your risk of vascular complications, and you want to perform anastomosis ideally outside the zone of injury. Postoperative care is just as important as the surgery itself, so you want to monitor pulses and a color closely. You want strict immobilization and elevation in the first week to prevent excessive swelling, and then a dangling protocol is there to gradually condition the flap to withstand the venous pressure and gravity. Okay. And in terms of newer techniques that we're using, the SPY technology, as Dr. Terry introduced, coupler devices to make anastomosis easier, and implantable Dopplers. Great, thank you.
Muchas gracias a todos nuestros ponentes por todos estos conceptos muy interesantes, complejos a la vez, pero bueno, vamos a tratar de tomar lo más práctico para nosotros. Ahora el doctor Leonardo López nos va a presentar algunos casos y para lo cual pedimos a nuestros participantes nos den su opinión. So we're going to show some cases from Dr. Leonardo López to comment by all the panelists. Thank you.
Muchas gracias, muy amable, doctor Luis Padilla. Y gracias también al doctor César Álvarez por la oportunidad de presentar algunos casos que tenemos. Vamos a ir de la cubierta de lo más simple hasta lo que se vuelve más complejo o por lo menos técnicamente mayor, ¿no? Como este caso, este masculino después de un accidente de auto, tiene esta lesión tan severa en el antebrazo, una lesión pasiva de partes blandas, después de realizar algunos desbridamientos e incluso reconstruir arteria, ¿sí? Se realiza esta cubierta cutánea con piel, injertos de piel, ¿sí? Se logra cubrir. La evolución funcional del paciente es esta. Podemos ver que, bueno, la cubierta se logró completamente. Esta es la evolución del paciente. Este otro caso, un paciente también por accidente de motocicleta, 22 años. Vean la lesión que tiene en partes blandas, tanto en el dorso de la mano como en el antebrazo, en la parte dorsal también.
Doctor Leonardo, este otro caso nos está mostrando.
Ok, gracias Luis.
Buenas tardes.
A ver. ¿Ahora?
No, se está compartido, pero no se visualiza.
¿Ahora, Luis?
No aún, Leo. Mientras vemos estos detalles técnicos, Leonardo, no sé si me permitas hacer una pregunta a los panelistas mientras...
Por favor.
Continúas. Hay varias preguntas, pero varias van dirigidas al sistema BAC. Do you use the BAC system in conjunction with the flaps, or do you don't use it regularly?
That's a great question. I'm happy to respond to that. We use VACs in many scenarios. I'm very careful when I use VACs in the setting of a flap, either free flap or local flap. I have used VACs for covering skin grafts on top of gastrocnemius rotation flaps, and they have all done well. I've not had a muscle flap die from having a VAC put on it. For fasciocutaneous flaps, especially for ones that are maybe pushing the boundary of the length to width ratio, I would recommend I would probably recommend not doing a VAC if you can avoid it. I think that even on sometimes on low settings, the tension that the vac can put when it sucks down may cause some degree of compromise of blood flow. So it would make me nervous. I would have a hard time sleeping at night, you know, if the vac is kind of sucked down and kind of putting extra tension on the borders of the flap. So it's great for skin grafts, and I love to have vacs on all my skin grafts, but for the skin grafts that are adjacent to a flap or a free flap especially, I tend to not use it and only use just light dressing, Xeroform or a bolster, something like that.
Anyone else, do you want to make a mention? Ok, hay otra pregunta aquí acerca de las lesiones más comunes en la tibia, en las fracturas expuestas de tibia, es una exposición en el tercio medio o en el tercio distal. En un caso, por ejemplo, de 5 centímetros de defecto y que queramos hacer un cierre temprano dentro de las primeras 72 horas, con una exposición ósea e incluso del implante, ¿qué colgajo sugieren que pueda ser más fácilmente realizado por un cirujano ortopedista, un colgajo de transposición o rotacional? What I ask is, in the cases of distal tibia fracture, open with 5 centimeters of defect, and in case you want to make the closure in the first 72 hours with exposure of the bone, even the hardware, which flap do you suggest it's easier for an orthopedic surgeon to do, a transpositional or rotational?
I'm happy to answer that one also. You know, my personal opinion is that a transposition flap in the distal third of the lower extremity is a better flap than a rotation flap. I think it's very difficult to rotate in enough tissue, especially if you have a fairly medium, you know, sized wound. Transposition flaps are you know, you're lifting up and you're elevating the entire rectangle of tissue, so you can make it go, you know, transpose and cover the wound as long as you design your flap well and adhere to those principles. Dr. Ragazar, do you have any thoughts on that?
Sí, estoy de acuerdo con Dr. Terry y a veces puedes usar ambos, depende en la cantidad que necesita cubrir. El colgajo transmisión es muy fácil, pero es mejor para el distal tercio. Si es como algo entre los dos, es posible a veces usar los dos, el soleo para cubrir el medio tercio y la transmisión para el distal. Pero los dos no es difícil si respeta la anatomía y los conceptos de como el ratio para el flap transmisión. Transmisión es fácil y un cirujano ortopédico puede hacer los dos.
Dr. Dean, any suggestion?
Yeah, I would agree with that as well. For most orthopedic surgeons, I think if you understand the concepts of our local flaps, those are probably going to be our best friends for that. You may even push it to propeller flaps. And perhaps a gastroc as well. But once you get in the realm of like free flaps, for example, I think it becomes much more difficult to achieve with just routine orthopedic training.
Quería mencionar que antes de COVID nosotros teníamos un curso que se llama el Smart Course con nuestros amigos de FEMECOT que en los 2 años los hemos hecho en Guadalajara. Es un curso de 3 días de colgajos. Ojalá podamos empezar esto otra vez el año que viene.
Muy bien, muchas gracias. César, ¿tienes una pregunta?
Sí. Yeah, I'm gonna do it in Spanish first. Voy a hacer en español primero. Tengo un paciente que tiene una herida en talón, aprovechando que estamos hablando de la extremidad inferior, una herida, una pérdida cutánea en el calcáneo de aproximadamente 3 o 4 centímetros con exposición ósea. ¿Qué recomendarían? ¿Será posible un VY o qué tipo de cobertura se haría? We have a patient with a exposition of the calcaneus bone, about 3 or 4 centimeters of exposition. What would be the best way to cover? Talking about the VY would be possible, or you suggest another kind of approach?
That's a great question. And unfortunately, we didn't have time to talk tonight about all the different types of flaps that are possible, because there's hundreds and hundreds of them. Specifically for a calcaneal 3 centimeter defect, there is a flap called the reverse Searle flap, which is ideal for that. And that flap, it's a very tricky flap to do, and it has a fairly high rate of partial ischemia or partial necrosis. But for that particular area of the body, there's not really any local tissue that you can rotate in there, or at least it's very, very difficult. So a VY, none of those local flap options would be very great for a heel wound, or at least I think it would be very difficult unless the wound was, 2 centimeters, I think you could do. You could do 2 V to Y flaps from either side, advancing in towards the center. 3 to 4 centimeters, now you're starting to push the boundaries, because the skin on the heel is very, very adherent to the calcaneus. So the surrounding skin is not going to move very much. On almost any other part of your body, you can get a V to Y flap to advance at least, to some degree. And if you do 2 flaps, one on either side, you can advance them. Each flap only has to travel half the distance to reach the center. So yes, there's many different types of flaps. The reverse Searle flap is a little bit more technical challenge, but that is another flap that can be used to cover exposed calcaneus defects.
Okay, thank you very much. There's any other opinion about it for one of you, our professors?
Como lo que dijo Dr. Terry, es una área muy difícil de tratar con algo local, porque no mueva fácilmente la piel cerca de calcaneus. Aquí lo que hago yo en general es un colgajo libre, y mis compañeros de ortopedia pueden construir una fijación external para mantener la piel arriba, para no poner presión en el colgajo postoperatorio. Pero si no puede hacer el colgajo libre, la mejor, la otra cosa para hacer es el reverse Searle, pero es un flap difícil, y también en general cuando hagamos reverse Searle, hagamos con un delay, como lo que habló Dr. Terry, para que aumentar la posibilidad de tener éxito con este flap, este colgajo.
Muchas gracias. Muchas gracias.
Si quieren empezar con colgajos, el reverse Searle es uno que es un poco difícil para empezar. Mejor tratar con algo como un gastro, ¿no? Que tiene más seguridad.
Muy bien. Bueno, después de algunas cuestiones técnicas, vamos a seguir compartiendo algunos casos clínicos. Como decía, este masculino, 22 años, accidente en moto, que tuvo esta lesión en el dorso de la mano y en el antebrazo. Después de que se le realizó en alguna unidad médica desbridamientos e incluso manejo con back hasta de 10-12 lavados quirúrgicos. Este es el aspecto final. Recuerden que también tuvo pérdida de tendones, ¿sí? Es muy importante hacer notar el irrigar y no desbridar siempre. Y todo lo que se vea necrótico o con un mal aspecto hay que retirarlo. Esto es lo que finalmente se le hizo, y el Servicio de Cirugía Plástica decidió poner un injerto de piel directamente sobre la zona, ¿sí? Posteriormente, y con la limitación que tenía el paciente para extender, se decide llevar al quirófano. Esa es el área que decidimos retirar, puesto que la piel estaba directamente sobre el hueso y es una parte que no debe de ser. Ahí vemos la limitación para la extensión del segundo y del tercer dedo. Se toma de los pies, se lleva para reconstruir la parte tendinosa de los extensores, como vemos en este ejemplo, ¿sí? Y este es uno de los objetivos que queríamos. Después de hacer el desbridamiento y reparar la parte tendinosa, decidimos llevar, en este caso, un colgajo chino o un radial flat también. Y este es el procedimiento que decidimos llevar. Ahí se ve el ejemplo, cómo estamos levantándolo, ¿sí? Y poder hacer la cubierta completa. El paciente inicia una rehabilitación temprana. Este es el aspecto del mismo caso. Y vemos posteriormente, pues, el nivel de aparte de la cubierta que se toma, la funcionalidad que este paciente puede llegar a tener. Otro caso, un accidente también, motocicleta, 24 años, con una lesión severa, partes blandas, incluso podemos ver pérdida de... ¿Sí?
No, el nuevo caso no se está viendo.
Ops, disculpa. Veamos ahora. Comparto. Aquí. Ahora, Luis.
No, está compartida la pantalla, pero no se ve.
Intento una más. ¿Y ahora, Luis, se logra o no?
No, no se ve, Leo.
Ok, si quieres vamos entonces a las preguntas. Me disculpo por no sé qué sucede aquí.
Sí. Muy bien, bueno, si les parece bien, vamos a hacer una última pregunta del panelista para finalizar. Hacen una pregunta que si para hacer un cierre de los colgajos rotacionales o locales, cuando los cultivos estén negativos, es cuando hacen ya estos cierres, o entre más temprano tienen un mejor pronóstico. When you do the local flaps or rotational flaps, you must wait until negative culture, or earlier it's better.
Yeah, I mean, that's a common question that comes up many times. I think that if you're in the acute setting and you've got some necrotic tissue, it's really when you feel like you've done a fully adequate debridement. That is the sole determining, the only determining factor as to whether it's time for coverage or not, is whether the wound is clinically fully debrided and clean. In some situations, if you're coming back for an infected, tibia non-union, you might want to take cultures and serially debride until you get negative cultures before doing a complex, definitive closure. But I think in the more initial trauma setting, I think as long as you clinically have debrided all necrotic tissue, then you can proceed with coverage. And some people even proceed with coverage in the same operative setting as the debridement. If there's a question about viability of tissue, what will survive, what won't survive, you do your initial debridement, and then you can give it some time, a second look or a third look to determine which tissues are surviving and not. But once you are sure that all necrotic tissue is gone and the remaining tissue is viable, that is the time to do your flap.
Yeah, I agree with Dr. Terry on that, in the acute setting, we're not talking about the osteomyelitis cases. In acute settings, sometimes while you want to get coverage, you don't want to necessarily delay it for no reason. Sometimes it's worth taking it back for a second look, especially for like large wounds or contaminated wounds, where you're suspecting that the zone of injury may declare itself even further. Okay, and you want to be careful of that because you don't want necrotic tissue in your wound bed just because you want flap in the same setting.
Sí, lo importante, como están diciendo los profesores, es el desprendimiento, es lo más importante. Y en las tibias expuestas, los huesos expuestas, si algo que pasa hace un par de días, nosotros normalmente no tomamos culturas, pero si ya tenemos confianza en nuestros, que está limpio, entonces nosotros tratamos a cubrir cuando ya está estabilizado el hueso. Y a veces también ayuda, si puedes cubrir con músculos, a veces ayuda también para traer vascularidad a la fractura.
In terms of taking cultures in your initial debridement in the acute setting, I think the literature has shown us that it's not very helpful. In fact, if the wound actually does get infected, oftentimes it's going to be a different bacteria than what you're going to culture if the cultures are going back positive in your initial debridement.
Well, in the name of Orthopedic Medical Society of Guadalajara, Jalisco, Mexico, I want to say thank you again to Dr. Nicholas Lee, Dr. Michael Terry, Dr. Payne Moran-Gozar, Dr. Anthony Dean, y también al Dr. Luis Padilla y al Dr. Leonardo Lopez. Thank you to all of you, because without you, we couldn't make this webinar possible. And thank you basically to Dr. Nicholas Lee for his commitment and for his prompt response to accepting on all the professors without any hesitation to be with us tonight. Thank you very much. And it was very, very productive, and we learned a lot. And we are very sure that our patients are going to be the benefits from this talk. Thank you very much again. We hope soon we're going to make this possible to do it alive in Guadalajara or another part of the country. Thank you very much.
Thank you. Muchas gracias.
Thank you.
Muchas gracias.
Our pleasure.
Leo, me encantan tus casos.
Les estamos esperando.